So this is Khurram Nasir and you're watching Optometry with Khurram, and today's topic is regarding the management of refractive errors in a special age group like from birth to 8 years, right? And you know very well that this age group is the most critical age group while we are dealing with the refractive errors, like while we are dealing with hypermetropia or myopia or astigmatism, right? So we have, being a good clinician, being a good optometrist, we have to be very careful while we are dealing in that specific age group, right, from birth to 10 years, because the methods are totally different in different age groups in terms of refraction, right? So we have different questions in our inbox, like in case of hypermetropia, either we should go for full correction or under correction in a child or in infant, or in case of myopia, either we should go for full correction or under correction, right? And same as in the case of astigmatism. So let's learn different clinical important points regarding the refraction, regarding the clinical refraction in children. So let's go in the studio. So first of all, we will discuss about the specific refractive error, which is called which is the most common refractive error actually, and that is in infants, in children specifically, right? And that is hypermetropia or hyperopia, right? So what is hyperopia? You know very well that the hypermetropia is a state of refraction, or it's a state of refractive error in which the light rays are coming from the infinity. The light rays are parallel, so we can say the parallel light rays are coming from the infinity and are focusing behind the sensitive layer of the retina, right? And that specific refractive error is called the hypermetropia. And in the clinical definition is the refractive error, the state of refractive error in which the plus power of the eyeball will get decreased, will get declined. That refractive error is called the hypermetropia, right? And before learning about the management of hypermetropia in children, we must have some knowledge regarding the emetropization, right? So first of all, we will discuss about the emetropia. You know very well, you're a good optometrist, and you know very well that emetropia is our normal eye. The light rays are coming and traveling through my cornea, through my aqueous humor, through my crystalline lens, via pupil, and through vitreous humor, and those light rays are focusing specifically on the sensitive layer of the retina, and that state of refraction, that normal state of refraction, is called emetropia. And in emetropia, I do not have any hypermetropia, I do not have any myopia, and do not have any astigmatism, right? So what is emetropization? Emetropization is actually a phenomena. Emetropization is actually a procedure, a process which starts from the birth, right? Remember, this is a key point. Every normal child, while he or she is delivering from the womb of his mother, he or she got the refractive error. I'm talking about the normal baby. I'm talking about the normal baby, right? So a normal baby will always got the refractive error, which is hypermetropia, and the range is from 2 to 6 diopters of hypermetropia. It could be 2, it could be 3, 4, 5, or 6. This is the range, right? But every normal child will get the refractive error, which is called the hypermetropia. You know very well that the normal power of the cornea in adult is 43 diopters, right, more or less. And for the crystalline lens, the normal power of the crystalline lens in adult is 15 more or less, right, diopters. But in case of child, in case of newly born baby, the power of the crystalline lens is very high than the normal, right? The power of the cornea is very high than the normal, right? So, and the axial length is very small. You know very well that in a newly born baby, the axial length is so small, more or less 16 to 17 millimeter, right? And what about the cornea and lens? The power of the cornea and power of the lens is maximum, but the axial length is so small, right? So these all parameters, like power of the cornea, power of the lens, axial length of the eyeball, these all parameters have to be traveled towards the normal, because cornea has to be traveled to the normal power, lens has to be traveled to the normal power, axial length have to be larger, 24 millimeter. You know very well the power of the the axial length of the eyeball is 24 millimeter. So the process in which all these parameters traveling towards the normal, traveling toward the emetropia, this process is called emetropization, right? And now let's discuss some we will discuss emetropization in detail in some next videos. So in this video we will discuss some important points in terms of clinical refraction in children, right? So first of all, we will discuss about the hypermetropia. You know very well, hypermetropia, as we have discussed, hypermetropia or hyperopia, right? So in hypermetropia, the light rays are focusing behind the retina. So we are talking about the children, right? Infants or newly born. So you have to prescribe full correction while you are dealing with the hypermetropia. When you got complaint of esotropia or esophoria. So if you got three different conditions, you will prescribe full correction in hypermetropia if you got three different conditions. Condition number one, if you got esotropia, right? Manifest deviation. If you got second condition is esophoria, right? Latent deviation, latent ESO deviation, esophoria. And what is the third condition? That is family history. Right? So if your patient has hypermetropia and if you got three different conditions, so suppose you have esotropia, intermittent esotropia you can say, or esophoria, or family history of esotropia or esophoria, right? Suppose if mother has esotropia or esophoria, if father has esotropia or esophoria, anyone in the family has esotropia or esophoria, then in these three conditions, you will prescribe full correction while you are dealing with the hypermetropia. And if you got moderate or high hypermetropia, then you will give maximum prescription, right? If you got moderate or high hypermetropia, then you will prescribe maximum prescription, or you can say you will prescribe full correction in terms of hypermetropia to gain the maximum visual acuity, right? Remember that this is a rule of the refraction, give maximum plus and minimum minus, right? We have a detailed video on this topic, you can watch if you want, the link is in the description. So I repeat, when you find moderate or high hypermetropia, you will give maximum number, you will give maximum prescription to gain the maximum visual acuity. And now the point which I'm going to tell you right now is most important, is most critical. What is that? That is hyperopic and anisometropia, because this is the specific age group, the children from birth to 8 years. This is the time those children, those age groups are the most vulnerable, are most prone to develop you can say the squint or amblyopia. So you have to take care of your patient, you have to take care of your child from amblyopia and squint, right? And suppose for example this hyperopic and anisometropia is the main reason you can say developing the hypermetropic and isometropic amblyopia, right? You know very well the amblyopia is a lazy eye. You do not have any, your patient do not have any specific pathology, but visual acuities get worsening with the passage of time. So we are discussing hyperopic amblyopia and isometropic. So what is anisometropia? We have a detailed video on that as well. Anisometropia, this is the most critical thing to deal with, right? So anisometropia mean we have different refraction in both eyes, the unequal refraction in both eyes. For example, in my right eye I got +1 in the right eye, and in the left eye I got plus you can say +2. So what you say? And your patient is a child, your patient is an infant, right? So one eye has +1 and one eye has +2.00, right? So you have to be correct this anisometropia. You see this is unequal refraction, one eye has +1, other eye has +2.00. The books says that you have to correct anisometropia in hypermetropia, or you can say you have to correct the hypermetropic anisometropia if the unequal refraction is of +1 diopters, if the gap, if the difference is of +1 diopters, right? But I say, this is my opinion, this is my experience, that you have to correct anisometropia when your patient is hyperopic, even it is less than +1, even if the difference is less than +1, right? Because it can cause, it can critically cause amblyopia, which is very dangerous for the child, right? So if I have +1 in right eye in my patient's eye, in +2 in the fellow eye of my patient, then I have to correct this anisometropia. So what are the procedures of the clinical refractions in a newly born to 8 years of child? You know very well that we have many videos on retinoscopy. So a specific procedure is there which is called a cycloplegic refraction. So we will perform cycloplegia, we will perform cycloplegic refraction, we will instill the drops in the patient's both eyes, we will dilate the pupil, we will relax the accommodation, we will paralyze the accommodation, and then we will perform the retinoscopy, and that procedure is called the cycloplegic refraction. Remember that if your patient is hyperopic and he is or she is uncorrected hyperopic from long time, right? He did not use any prescription, or she did not use any prescription for the long time, and now she or he visited your clinic and you find hyperopia in that patient, then what will you do, right? And the question is, and the answer is, sorry, then you will prescribe, you will recommend, you will go for the cycloplegic refraction, right? And while you are performing the cycloplegic refraction, you will get, obviously the patient is hyperopic, then you will find, for example, the prescription is +2 with 0.5 cylinder, for example, at 90° in the right eye, and +3 spherical with 0.5 cylinder at 90° in the left eye. So this is for the right eye and this is for the left eye. For example, after cycloplegic refraction, you got this number in right eye and you got this number in your left eye, in patient's left eye, right? But this is, you prescribe the best prescription. This is the best prescription ever you prescribe, right? This is the best prescription in the left eye you prescribed ever, right? But your patient is not comfortable. Your patient is complaining that he or she got headache, or she's a child or he's a child, so he is not comfortable or she is not comfortable in your prescription. What could be the reason? Either your prescription is correct or not. For example, your prescription totally fine, then what is the reason of complaining, right? So the reason of the complaining could be because this is important, right? Your patient was uncorrected hyperop for for a long time, right? And his brain, you know very well that there is a compatibility between eyes and brain, specifically the accommodation is totally controlled by your brain, right? And your patient is your patient is uncorrected hyperope, right? So he or she is using maximum accommodation, right? So when you prescribe him the glasses with +2 and +3 in right and left eye respectively, so when you prescribe plus number, refractive error is gone, but you know very well the compatibility between the brain and the accommodation is still there. Brain is still working to increase the accommodation of the eye. So in one case, brain is increasing the accommodation. When I'm saying increasing accommodation, brain is actually increasing the plus power, because the patient was uncorrected hyperope. So he was overcoming his or her refractive error with the help of the accommodation. He was increasing his plus power with the help of the accommodation. And now in case number 2, you prescribe +2 and +3 in terms of glasses as well from the external source, right? So in one condition, patient is increasing his accommodation, patient is increasing its plus power with the help of the accommodation, number 1. And you prescribe in condition number 2, you also prescribe plus number from the external sources, from the spectacles, from the glasses. So patient is totally confused. Before there was no any plus power, right? But now there are 2 plus powers, from internal source accommodation and from external source glasses or spectacles or convex lenses or plus lenses. So the power will be maximum, overcorrected, and the patient will be uncomfortable, right? So what should we do? Being a good optometrist, we have different type of managements, right? And number one is the number one management in this case is you have to reduce the plus power. Suppose it is plus 2, go for 1.5 or 1 in right eye, and in the left eye is plus 3, go for 2.5 or 2. And you will increase the power gradually and progressively, right? Because the brain will take time to inhibit his habit of increasing accommodation, right? It will go away with the passage of time. So the management number one in that specific case, the management number one is you must decrease the plus power in both eyes, and number two is you will give shots of in terms of exercise, you will prescribe shots of cycloplegic or cyclopen. And when you will instill cyclopen in the patient's eye, it will paralyze the accommodation, because your patient was habitually increasing its accommodation, right? And now it will go away slowly and progressively, right? So when you will instill the cyclopen or cyclopentolate in patient's eye, it will paralyze the accommodation, right? So the brain will slowly inhibit or slowly slows down its habit of increasing accommodation. And now we will discuss about the myopia. You know very well that myopia is the most uh, progressing refractive errors. But in children, you know very well the hyperopia is most progressively while just after the birth, right? Now myopia, you know very well that, for example, if we talk about the hypermetropia, hypermetropia will always stimulate esophoria or esotropia. And in contrast, the myopia will also stimulate the exotropia or exophoria, right? We have a detailed video on this topic, that why hyperopia cause esotropia and why myopia cause exophoria or exotropia, right? So you know very well, in myopia, patients are really concerned because in children, as I said that just after the birth, the normal refractive error is not emetropia. If your baby has emetropia, this is not normal thing, right? But if your newly born baby got hypermetropia, this is normal. And if your baby got myopia, this is not normal. It should be screening out, right? So in case of myopia, parents are really concerned that the number of the patient, the number of the child is increasing progressively. The patients are really concerned, right? So you know, you can teach, you can explain the parents that you know very well that in myopia the axial length of the eyeball is greater than the normal, right? And you can explain the parents that as the baby is growing, the eyeball is growing as well, right? So myopia will grow in the same terms, right? If the baby is growing, eyeball is growing. If the eyeball is growing, myopia will grow, right? Then the myopia will also grow up. So you can explain the parents who are very concerned regarding their babies, regarding their newlyborns, regarding their children. So you can explain them that as the baby is growing, so myopia will grow, and when the growth will be stopped, right, the myopia will be stable. And remember one thing, if you got high myopia in children, treat them, right? Because I read many research articles on myopia that a high myopic child will always lose his or her reflexes. The reflexes of that patient with high myopia, the reflexes of that child with high myopia will be go slow down, right? The movement of the hands, the movement of the body language is not stable. The hands movement is not stable. There would be a difficulty while recognizing the objects, right? The mobility of that patient will be compromised, right? I have read many research articles on that. So be careful in, if you got high myopia in children, treat them, right? Otherwise your patient will slow down his or her reflexes, like the mobility, like the recognizing something, like the mortality, right? So if you got any high refractive error in terms of myopia, just treat them properly. And now we will discuss about the myopic amblyopia. If we compare hyperopic amblyopia and hyperopic amblyopia and myopic amblyopia, remember one thing, that if one patient is hyperopic and one patient is myopic, so in case of hypermetropia, for example, a patient has +1 in right eye and +2 in left eye. So this is hypermetropia, right? And in myopia, a patient has -1 in right eye and -2 in left eye. Both are uncorrected. The hyperopic patient is not using glasses. Myopic patient is also not using glasses. So which patient is under the threat of amblyopia? Hyperopic patient or myopic patient? Which one? Remember that hyperopic. For example, if myopia has -1 in right eye and -4 in left eye, and in case of hypermetropia, the patient in the right eye has +1 and in the left eye has +2. So which patient is under the threat of the amblyopia? Still hypermetropia. What is the reason behind that? Because the hyperopic patient will always use accommodation. So the visual acuity is already compromised. Number one is the visual acuity of the hyperopic patient is already compromised, and he is also using accommodation. Number two, so there are two different factors which are worsening his visual acuity, right? Number one is accommodation, and number two is itself visual acuity, which is losing his plus power, right? So the hyperopic eye is more compromising, the hyperopic eye is more struggling. That's why the hyperopic eye or hyperopic patient is under the threat of amblyopia as compared to the myopic patient, right? So why not myopia? Because myopia is very comfortable at reading. The myopic patient can read his reading material very comfortably, very clearly. So his eye, the myopic eye, is only struggling at distance, but the hyperopic eye is very struggling at near and also using accommodation. So accommodation is actually worsening the hyperopic eye, and hyperopic eye is struggling at near as well. So both these two factors worsening and taking hyperopic eye towards the amblyopia, right? So if you are dealing with the myopia, if you have high myopia, and for example, if I must say, if you got a patient which is uniocular myopia, right? One eye has myopia and other eye has different number, or you can say one eye is totally fine. So this eye can cause amblyopia, this eye can shift towards the amblyopia, right? And the best the good treatment or good management for that, in that case, in uniocular moderate or high myopia, I'm talking about the uniocular one eye, right? So if my patient which is a child actually got moderate or high myopia, but that is uniocular in one eye, right? So I should go for the spectacles, right? And if the spectacles are not working, right, then go for contact lenses, right? Contact lenses is the best treatment in uniocular myopia or in uniocular moderate or high myopia. But we are talking about the children. We have to be very careful. We have to teach, we have to explain the parents that how the contact lens will be used. And now finally we will discuss about the astigmatism, right? You know very well that the astigmatism, in astigmatism, the different focal lines are formed. One is on the retina, one is behind the retina, one is on the retina, one is in front of the retina. Both are behind the retina at different position, both are different position in front of the retina. So we have mixed, we have compound, we have simple astigmatism, we have different types of astigmatism we have discussed in the last videos. So now we will discuss that if your patient, which is a child, which is an infant, got astigmatism, how you will deal that patient of astigmatism. Remember that just after the birth, you know, cornea is a spherical. Cornea has a specific shape, you know, right? So cornea at 360 degrees, so this is cornea, this is a frontal view, and this is cornea, this is a lateral view, right? So at every position of the cornea, the curvature of the cornea is different, and it grows, the curvature of the cornea grows in different pattern, right? So if you got astigmatism in your patient, right, you will not correct all the astigmatism, right? You will not correct the astigmatism, because after the birth or just after the birth and 1 or 2 years of age, your baby, your children could be highly astigmatic, right? But that astigmatism will disappear with the passage of time. Why? Because, as I said, the cornea has different curvatures at different sides, right? The crystalline lens has different curvature at different sides. So that curvature, that surface of the cornea, or that surface of the lens, or that curvature of the lens or the cornea will grow differently as the time will pass out, right? The cornea will get exactly at the specific normal position or normal location or normal surface, and then the curvature will be fine. And when the curvature will be fine, astigmatism will be vanished or disappear, right? But remember, when you have to be correct the astigmatism in children at the specific age of 3 years, if your patient got astigmatism of 1 diopter, then you will treat or correct that astigmatism. Hope this video is beneficial for you. We'll see you in the next videos.